Dear all, welcome to the new webinar. Welcome to Dr. Natalya Zymak that is here with me, and we are very proud to have you with us for this new webinar on the neurogenic bladder. And Dr. Zymak, please.
Ласкаво просимо, доброго вечора, шановні друзі та колеги. Сьогодні ми маємо приємність четверте зустрітись на нашій спільній серії вебінарів, яка присвячена спінальним дисрафізмам і яка, як ви пам'ятаєте, а хто не пам'ятає, долучився до нас вперше, вона організована спільно з ERN EUROGEN, Міжнародним благодійним фондом OMNI-NET Україна та Міжнародною федерацією Spina Bifida та Hydrocephalus. І сьогоднішній наш вебінар представляють професор Rien Nijman, дитячий уролог з Університетського медичного центру Гронінгена у Нідерландах, та професор Giovanni Mosiello, відомий уже вам, дитячий уролог із дитячої лікарні Bambino Gesu у Римі. Прошу, пане Mosiello.
Yes, and thank you, Dr. Zymak. And as we promised to you in the past webinar, today we have included the answer to your question on the website, and this is the system that we will use for all the webinar. So please do the question during our presentation. But if you don't have time, if you would like to do later, you have time to do the question. We have received some questions and some technical questions, very interesting. The first of all about the use of the duramadder plastics and when it is used. And it used normally for the prenatal surgery repair and in postnatal for reoperation. Of course, there is a choice of the surgeon. For when to perform the repair of the spina bifida and the hydrocephalus, again, you have the choice of the surgeon. There is a surgeon preference, but normally the colleagues perform separately in different time, and they perform before the closure and then the shunting. In some cases, when there is a severe hydrocephalus, they prefer to do the derivation before. Other question that has been done is about the use of the electroneuromonitoring during operation. Of course, it is useful and is something that is helpful for the neurosurgeon, is helpful for the patient, is helpful for all the other specialists that are involved for the treatment of these patients. But we know that in some center is not available. And the recommendation, of course, if you have, please use, because you could perform surgery in a safe way. And if you don't have, try to obtain by your hospital direction, because you could ameliorate the treatment. Regarding the shunting, if there is something better, different, on the different kinds, and again, you have to use what you have, of course, and of course, if you have an adjustable valve, is better. And in some cases, the flow regulating valves are used. But again, you have to perform this kind of surgery with the knowledge that what you have to do and in the better way. And of course, if you can use adjustable valves, could be better. And regarding the benefits of a fetal surgery for the urological point of view, and we know from the different experience, European experience, the North American experience, the MOMS study and the Brazilian study, that there is no effectiveness as for the ambulatory status or for the hydrocephalus. And we can suppose, as for the repair of the myelomeningocele, that the treatment can improve the urological status of this patient, reducing the indication for enterocystoplasty and or substitution. But at the moment, we have also to define a common approach from the urological point of view to evaluate the results of this kind of surgery. And I believe that was the last question, and the approach, of course, and in many cases, it left to the surgeon choice. And going to the webinar of today, and I don't know if Dr. Zymak, do you have other comments on this, please?
Я хочу подякувати нашим колегам, які брали участь у третьому вебінарі, виявились небайдужими і згенерували цілий ряд запитань. Відповіді, на які ви бачили, вони були відкоментовані професором Мосієло. Ви також могли прочитати їх, і можна так само звернутися і оглянути ще раз, переглянути їх на сайті. Дякую, професору Мосієло. Я не дуже почуваюся великим спеціалістом дитячої урології, тому коментування передаю вам.
Well, and I believe that we can move on and to the webinar of today. We are very proud to have with us Professor Rien Nijman. Professor Rien Nijman is a pediatric urologist in the Netherlands, in Groningen. He is a professor of urology. He published more 50,000 of reviewed papers. He is member of the Children's Committee of International Conscience Society, was previous chair of a pediatric committee in ICI, and actually is also the chairman of the EU senior credits collection and definition for the in Europe for European Association of Urology. And I believe that he is the best for presenting the classification, pathophysiology, and diagnosis. And I'm sure that you will enjoy his presentation. Dr. Zymak.
І я повторюсь, маю велику приємність представити наших сьогоднішніх спікерів. Професора Рієна Наймана, дитячого уролога з кафедри урології та дитячої урології університетської клініки Гронінгена, автора понад 150 рецензованих робіт, а так само і доктора Giovanni Mosiello, який є президентом Італійського товариства дитячої урології і керівником досить складного комплексного відділення хірургії нетримання сечі та нейроурології у дитячій лікарні Бамбіно Gesu у Римі. Запрошую вас, прошу, пане Rien Nijman, до слова. Говоритимемо сьогодні, повторюсь, про класифікацію нейрогенного сечового міхура, про патофізіологію та основні підходи до діагностики цього стану. Прошу.
Of course, if you wish to ask a question regarding the presentation, you can do so typing it into the question box. Some question will receive an answer during the webinar, and you can also submit questions after the webinar, and then you will receive the answer in the next webinar. And the answer, as I told you before, will also be published on the EUROGEN website.
Модус операнді щодо питань залишається таким же. Можна їх записати в чаті, можна переглянути в записі на Ютубі або надіслати електронним листом. Пане Rien Nijman, запрошуємо вас до слова.
Okay. Good evening, everybody. From a cold Groningen in the Netherlands. My name is Rien Nijman. And I will do this session together with Giovanni Mosiello from Rome. And I will start talking about classification of neurogenic bladders in Spina Bifida, something about the pathophysiology, diagnosis, and treatment options. I have no specific disclosures except that together with Christian Radmayer, I am co-chairing the working group on spinal dysraphism. We have just finished writing the guidelines on the management of neurogenic bladder. I'm living in the Netherlands, that is circled and indicated on this map. and I'm working in the city of Groningen, which is all the way up north. It's about a 2.5 hours drive by car from Amsterdam. Groningen has had a university for a very, very long time. We have about 40,000 students, and we also have a university hospital. Actually, that's the second largest hospital in this country, and it is located in the center of the city. Spinal dysraphism, that is the topic for tonight. It's not only about spina bifida. There's a whole spectrum, including anal rectal malformations, cloacal malformations, spinal dysraphism, spina bifida, tumors, infections, traumatic lesions, although in children they're quite rare. What is important, and I'm emphasizing this right from the start, that most of these lesions are not complete lesions as you would expect in a traumatic injury of the spinal cord. For normal and optimal functioning of the lower urinary tract during the storage phase, it is very important that urine can be stored there at low pressures. The bladder has to be stable. We have to be able to adjust the sphincter tonus. And at the end of filling, when the bladder is full, you want to feel the desire to void. At the same time, during filling, the upper tract should be able to empty completely. And there's always a low pressure in the upper urinary tract. During voiding, and once we're toilet trained, we can start voiding voluntarily with a powerful stream. There shouldn't be any significant post-void residual. And there must be a good coordination of the detrusor contraction and relaxation of the pelvic floor muscles. And of course, we can interrupt our voiding. It is not only necessary to have a normal bladder, but you also need to have a normal connection to the central nervous system, and especially the cerebral cortex, but also the pontine micturition center and the periaqueduct of Gray play a very important role in normal voiding and storage of urine. There are also a couple of nerves, parasympathetic nerves, sympathetic nerves, and we do have a sensory connection and somatic nerves from the bladder to the brain. In this slide, you can see what happens at different levels. Very important for normal voiding and storage of urine is the pontine coordination. The bladder itself, the bladder wall, is composed of smooth muscle cells, and they like to contract continuously. Cortical inhibition of bladder contraction is extremely important. And there has to be a good connection between the brain and the bladder. And here you can see that there are many conditions that can intervene with normal connection or normal function of the brain, the spinal cord, and the bladder. Most of these abnormalities that are listed here are not relevant for this talk. We will focus in this talk on the distal part of the spinal column, because most of the spina bifida children have a lesion at the lumbosacral level. These are some pictures illustrating what we see after birth in a child with a spina bifida. Some of these lesions are clearly visible. Some of them are a little bit hidden and only visible when you do a good inspection of the back. There may be a sacral dimple or a sacral lump, and they all may be an indication for a lesion of the normal neurological innervation of the bladder. Some hair, abnormal color of the skin may be present, and they may all be indicative for bladder dysfunction. here you have some abnormalities that are more familiar probably to you, Spina Bifida and other lesions like abnormality of the sacrum, sacral agenesis. They can also cause a neurogenic bladder. Many patients can be nowadays can be diagnosed prenatally by ultrasound, and then an MRI scan can be done. And this is an example made at 22 weeks of gestation, showing Spina Bifida at the level of L3. And you can see abnormalities of the ventricles. They are dilated, and a Chiari-2 malformation. On the other slide, on the other pictures, you see a prenatal operation. In this case, an open intervention. The uterus is opened, and you can see the defect on the backside of the child that can be closed. And on the right, you see the same child after birth, and the defect on the backside has healed very, very nicely. So what is important? It is a broad spectrum with a lot of different entities. And contrary to spinal cord injuries with transection of the cord, these lesions are mostly incomplete. And the extent of the lesion may change over time. And also the level of the lesion does not always correspond with the extent of neurologic problem. Secondary tethering of the cord may occur later on, and bladder dysfunction will change over time. Bladder dysfunction is a dynamic process. It's not static, and therefore the management will change over time as well. What are the problems that our children suffer from? Well, most of them have urinary incontinence, recurrent urinary tract infections, constipation, also very important. And you have to realize that impaction of feces will influence bladder function. They also suffer from incontinence of stool. And when the bladder has a hostile character, I will come back to that later on, the collecting system will have high pressures. And that automatically will lead to a loss of renal function after some time. And especially the combination of high pressures in the collecting system with urinary tract infections may be devastating for the kidneys. When the children grow older, we also have to address sexual function and dysfunction. And you have to remember that almost all of them have poor self-esteem and an impaired quality of life. At birth, almost all children born with Spina Bifida have normal upper tracts. In a very interesting study that was published last year, an American group found that after 30 years of proper management of their children, they found a 30-year risk for end-stage kidney disease in 2%. And the ones that had been managed with a vasectomy, and that is a subgroup, they had the same risk in 10%. And that is in all the children who had proper management. Now, if you do not have all the facilities to properly manage these fits, within 5 years, more than 60% will have upper tract damage, like reflux, hydronephrosis, and renal scarring. And therefore, it is extremely important that all children should have regular ultrasound studies done, at least in the beginning a cystogram. DMSA scans are equally important, as are the urodynamic studies, and we like to combine that with video urodynamics. I'm not going to talk about the prenatal team, but especially the postnatal team is extremely important because the management of spina bifida is something that has to be done in a multidisciplinary session. And neurologists, neurosurgeons are part of that, together with the pediatricians, radiologists, urologists, sometimes the surgeon, depending on the hospital, orthopedic surgeons, specialized nurses, social services, psychologists, physical therapists, and a very dedicated spina bifida coordinator is an absolute must in my view. When children get older, you have to transfer them to the adult services, and transitional team is equally important. Most of all, I would say that both the whole team, all participating members, but also the parents and the patients have to be educated. When you compare the results of prenatal closure versus postnatal closure, there are a couple of things that have become very evident. And the first two are that the number of children that need a shunt to drain their ventricles is about half compared to the ones that have had postnatal closure. So there's a significant reduction in the number of shunt placements. Also, the motor outcomes and ambulation in general is better in prenatally closed spina bifida patients. There's still discussion whether an open procedure is better or worse than an endoscopic procedure, but that is out of the scope for this presentation. When we look at the urological outcomes, it is kind of disappointing that we haven't found any significant benefits. Some have found no benefits at all. Others have found some benefits in the sense that they may need less CIC, and volitional voiding is more frequent in the prenatally operated ones. But otherwise, when you look at the need for anticholinergic medication, the need for CIC, it is equal in both groups. Whether prenatal closure has a positive effect on incontinence is still an open issue. The problem is that most of the parameters used to compare the groups are rather subjective. And that is also true for urodynamic studies. The problem is that they are still not really standardized, both in performing the study as well as the reporting of urodynamic parameters. And the other thing is that most of the studies that you will see in the literature do not or have not included urodynamic studies in the past. So there's still room for improvement here. When you look at the group of patients that have been closed postnatally, it is very clear that immediate closure gives better results than late closures. So what are the treatment objectives? Well, probably one of the most important things is that we have to preserve renal function. At the same time, and I will give some examples later on and come back to that later, we have to prevent secondary changes of the bladder wall, promote continence both for urine and feces, and improve quality of life. That means that we want to have them out of diapers at a normal age, both for urine and feces. We want to have them as independent as possible. And later we have to address issues like sexuality and fertility. As you can see here, most or almost all patients suffer from urinary incontinence, recurrent infections, and constipation. More than 40 years ago, McGuire in the US as demonstrating the association of reflux and renal damage in the majority of patients who had high pressures in the bladder. Leak point pressure above 40 centimeters of water was the cutoff. So we now know that both the leak point pressure, the compliance of the bladder, and the trusor sphincter dyssynergia correlate with renal deterioration. When you treat them properly, there is no correlation anymore. So that shows the importance of proper management. And what you can see on the picture on the bottom left, at a certain point, when the bladder is filling, you enter the danger zone. Pressures go up, and that has a negative effect on the evacuation of the upper tracts. I will show you some examples of urodynamic investigations, and the next workshop, the webinar, will be on urodynamic studies only. So I don't want to go into detail on these pictures yet, but what you can see here, and I'll point that out, this is the trusor pressure, and you can see that there are contractions, several, and on this side even more frequently, where the bladder pressure reaches more than 100 centimeters of water. Also, when you lose the elasticity of the bladder wall, compliance goes down, and that is this red curve here, also the trusor pressure here. And you can see that at a rather low filling of the bladder, pressures are extremely high already. So this is an example of a poorly compliant bladder with high pressures during filling. This is another example actually showing the same thing, except that on the other one, you could also see that the bladder neck was open, but here you can see there's a very typical appearance of a neurogenic bladder, like a Christmas tree, very trabeculated, and high pressures during filling. So the question is, how long and what volume can the bladder store at the safe low pressure? And that is crucial in all these children. When you do your dynamic studies, we do it to define the pattern of bladder sphincter dysfunction, to determine whether the bladder is hostile or not. And you see here 4 pictures of the bladder wall and the sphincter. Here you can see the trusor, very thick bladder wall, overactive, and also a very overactive sphincter. And what this means is that when you have high pressures in the collecting system in the bladder, that will have damaging effects on the upper tract. So that one, the top right, has a very bad influence on the upper tract. And the same is true when the sphincter is overactive, and equally when you have an overactive bladder with a normal sphincter. The same is true for urinary incontinence, and you can say that when you have an overactive sphincter, probably incontinence is not bad, but in all the other instances, incontinence will occur. So it's the bladder pattern that is important. So when you make a table like this, what are the characteristics of the bladder? When you have a low-risk bladder that is safe for the upper tract, or when you have a very high-risk hostile bladder on the right. In this case, you can see that compliance is usually extremely low, poor, capacity is low. There is usually the truth of overactivity, and the pressures during the maximum filling pressure and leak point pressure will be above 40 centimeters of water. And in all the other cases, it is more or less a safe bladder. Now, when you look at the topic of the drusen sphincter dysynergia, that is a difficult issue. It is, from urodynamic studies, not always clear, especially in very young children, whether there actually is the drusen sphincter discoordination and dysynergia. But in a hostile bladder, by definition, it should be there. Now, what happens to the bladder wall when you have an overactive sphincter? After some time, the overactive sphincter will start to act as an outlet obstruction, and therefore the bladder wall will change. What we see is a loss of elasticity, loss of compliance, and an increase in the drusen overactivity. So what happens is that, in essence, it's a functional obstruction, but it will act as an anatomical obstruction. And the end of the story is that you have a thick-walled bladder with loss of contractility and compliance and high filling pressures. And these alterations can and usually are irreversible. And this was shown in an animal study in our university in Rotterdam, where we did some animal studies with urethral obstruction, and we looked at the bladder wall, what happened. And what you see here is that when you start with a normal bladder, it looks like that. After a couple of weeks of obstruction, only 2 weeks, you will see that major changes occur. And after 10 and 11 weeks of obstruction, you will see that the whole architecture of the bladder wall has changed. And there is a change in the composition of collagen. And the end is that you end up with a small, very tuberculated and stiff bladder with poor compliance. Now, what do we need to do to preserve renal function? Well, first of all, we have to eliminate high pressures in the bladder and the collecting system. And we also have to prevent secondary changes of the bladder wall. And we know that when we can achieve this by emptying the bladder at regular intervals, and we use CIC for that, and treat the drusen overactivity with medical drugs, and at the same time promote bowel emptying. And we have always advocated a proactive strategy. That means that we start treatment right after birth, and it favors greater benefit in preventative management and may decrease the risk of renal dysfunction compared with expected management. In this scheme, you can easily see what we do. We preserve renal function, promote continence by maintaining low pressures, regular emptying, and prevention of urinary tract infections. And therefore, early start of CIC is recommended together with anticholinergics and bowel control. And maybe later on, when that doesn't help enough, bladder augmentation, bladder neck procedures, and continent diversions may be coming into the picture. Promoting the quality of life at the end of the day is really very important. This is an example of a child before starting CIC and anticholinergics. So this was not a child with proactive management, but expectant management. And you can see that the what the influence is of anticholinergic medication and starting intermittent catheterization. It is evident that the dilatation of the upper tracts is much less now. So what we usually do is start with pharmacological treatment and prevention of the trusor overactivity. There are a couple of drugs listed here. The drugs that we usually use when the child is a newborn is oxybutynin. It has a liquid formulation as well, and that means that titration of dosages is much easier. But depending on where we live in Europe, we can choose other drugs that are available. Most of them are not allowed for children at a very young age, so we can only use them off-label. And what I would like to stress also is that anticholinergic medication has an anti-proliferative effect on the smooth muscle component of the wall. And the use of anticholinergic medication is important to prevent the secondary changes of the bladder wall. Other advantages of early starting CIC and anticholinergics, and I know that there will be a special webinar on this particular issue, is that it is easier for parents and children to learn and accept that they have to put in the catheter a couple of times a day. Lower pressures and adequate emptying are promoting normal renal developments. There is a decrease of urinary tract infections. It promotes dryness, and it prevents secondary bladder wall changes and avoids the need for bladder augmentation in the future. And it's interesting that more than 20 years ago, it was already stated by Stu Bauer from Boston. At the present time, the only individuals who seem to require a bladder augmentation in later childhood are those who have not been managed prophylactically since early infancy. And internationally, everybody has the same experience. The number of children needing a bladder augmentation later on in life has really tremendously decreased. Now, if pharmacological treatment fails, you may want to consider intravesical oxybutynin that has a little bit less side effects. You can also switch to another anticholinergic medication, of course. Botulinum toxin injections of the bladder wall may be extremely helpful. The use of alpha blockers, some people believe in them. The proof that it really is very effective is quite weak. And certainly, when all these conservative measures fail, you can consider bladder augmentation, sphincter reinforcement like sling or bulking agent, although they are not extremely helpful, or an artificial sphincter, continent diversions with a metrophenol or a multi-channel with or without augmentation are also on the list. So when do we perform surgery? Well, it's usually when there is persistent urinary incontinence, and that usually is in combination with an insufficient closure of the bladder neck. But usually it's in cases with small bladders, with poor compliance, therapy resistant to trusor overactivity, and as I said, sphincter incompetence. But sometimes children develop problems with CIC. They may have some urethral issues. Children and young adults in wheelchairs, they will tell you that the time they spent on a toilet emptying and irrigating their bladders, the help they need from caretakers is really quite burdensome. So you can give them a lot of independence. It saves time, and the quality of life will usually improve. Some patients need a surgical intervention because of fecal incontinence and constipation, and that is only if medical treatment and enemas fail. This is an older patient in a wheelchair, and at this moment she's working as a secretary in our hospital. And she will tell you that since she had the continent diversion in her umbilicus, she is much more independent. She spends less time irrigating and emptying the bladder. She is not dependent on other people. She doesn't have to make a transfer from her wheelchair to a bench or some other facility. And it really helps to improve her self-esteem. Overall, after a continent diversion, more than 90% of the patients are completely dry. But there is a high price to pay. There are many complications, and many of them, of the patients, they will need 1 or 2 redo interventions because of stomach stenosis at the level of the skin or the bladder. Some will form stones, and in some there may be persistent leakage of urine. And the list of complications that may occur is quite long, actually. I would like to conclude by saying that every child with spinal dysraphism needs a full workup by a pediatric or a dedicated urologist. Urodynamic evaluation is the cornerstone of urological management. Lifelong follow-up is mandatory, and a multidisciplinary approach is absolutely the best for the child and the parents. Bowel and bladder management go hand in hand. And a proactive approach probably is best for most children. That means starting CIC early and medical treatment to combine it with. And bowel irrigation leads to fecal continence in almost all Spina Bifida patients. Continent diversions, they are an enormous improvement. They improve quality of life and the independency of the patients. Thank you very much, and I will go now to Giovanni. Thank you. Bye-bye.
Dear all, thank you very much for your participation to the webinar of today. I believe that after this very complete presentation by Professor Rien Nijman, nothing is to add. Here are some remarks by myself about urinary incontinence and occult spinal dysraphism, occult spinal dysraphism during age, and occult spinal dysraphism in other malformations. Occult spinal dysraphism is quite common, so please consider it when you treat a boy or girl with a urinary incontinence. It's useful to check the lumbar area, but it's also useful to check the foot and to check reflexes in your. Second point, bladder function in occult spinal dysraphism can change during time, and it's possible to observe these changes by ultrasound and urodynamics. These changes could be related to a secondary tethering or progressive syringomyelia, and these changes can occur mostly in some ages, as the first 3 years of life and puberty. Other point to consider that there are some changes in the puberty in girls for estrogenization of the urethra, in boys for prostate growth. Last point to consider is that in some children there is a high risk for occult spinal dysraphism, as for anorectal malformation. Again, it's useful to consider this and to check it with the MRI
and when useful with urodynamics. Thank you very much for your participation again.
Thank you very much, Professor Nijman and Professor Mosiello. Дякуємо нашим сьогоднішнім шанованим спікерам. І я сподіваюся, що ми отримали дуже багато цікавої і важливої в практичному і в теоретичному сенсі інформації. We have several questions.
Yes.
I see in our chat.
Yes, Dr. Zymak, thank you very much. I think that we received 5 very interesting questions, and I will try to answer now. And of course, we will remember that you could receive the answer later on the next webinar and also on the website. The first question is, how do you code a neurogenic bladder according to ICD? The code of a neurogenic bladder is 596.454. And we have other code of ICD that is 59653 is a bladder paralysis, 59651 for hypertonic bladder, 5964 for atonic bladder, 59652 for low compliant bladder, 78821 for incomplete emptying of the bladder, 78830 for urinary incontinence. And one point to remark that we don't have a NORFA code for neurogenic bladder. The second question is, how is a neurogenic bladder is classified when it's impossible to conduct urodynamics? Good question. Not in all the center you have a urodynamics. And of course, the suggestion is to refer the patient to a center when there is a urodynamics. But other point to stress that you have to acquire a neurodynamic mind, and for this it will be useful to train anyway in a center, in a specialized center where urodynamic is available. Because if you acquire a urodynamic mind, you could do a diagnosis of neurogenic bladder. Of course, urodynamics is useful, urodynamic is better because this examination permits to have confirmation of your suspicion and also to better define the situation and the risk for the upper urinary tract and for the continence management. And what is the correct diagnosis in urinary disorder in patients with spinal cord injury? The spinal cord injury is one of the causes of the neurogenic bladder, as Professor Nijman presented. And we know that spinal cord injury is quite rare in pediatric patients. Anyway, it's possible to observe. There is an increasing number. I suppose that now in Ukraine, we have an increasing number due to the war, but we have also in our countries due to car accident survival. And the neurogenic bladder in a spinal cord injury is mostly observed is a neurogenic diffuse overactivity with a dysynergia. Other point to remark that while it is quite very difficult to observe in a spina bifida patient autonomic dysreflexia, on the opposite, it's possible to observe and is very dangerous to observe autonomic dysreflexia also during urodynamic examination, and we know that we have the risk of autonomic dysreflexia for lesion above T6. And the other question is, how long after the start of a conservative treatment should a urodynamic examination be performed to assess its effectiveness? Normally, we have the range of 3 months. That is not useful in order to understand if there is an answer by the treatment. And other suggestion is to avoid to change the treatment after 1 month, to change. And as the Professor Nijman presented, we have a different anticholinergics, but before to shift to another treatment, it's better to be sure about the real effectiveness. And so 3 months could be considered a useful marker. And it's possible to prescribe, last question, oxybutynin before conducting a urodynamic examination if there is a lesion of the upper urinary tract with a neurogenic bladder present. The answer is yes, of course. You can do that. And again, thinking, what is the aim of a urodynamic evaluation? If you have a patient that you are treating, you have in the treatment, and you would like to see if the treatment is effective, you have to leave the oxybutynin. Otherwise, if you receive a patient from another center, for example, for a second opinion, and you don't know this patient because you never have performed the evaluation, urodynamic evaluation, maybe it's better if you are a safe condition to stop for some days the oxybutynin in order to be sure that you go to evaluate by yourself the urodynamics and you have a clear point of view of this patient. I leave the podium to Professor Rien Nijman and Dr. Natalya Zymak if they have other comments for this question.
Well, thank you, Giovanni. It is quite remarkable that I completely agree with your answers. I know one of the reasons is that we have been working on this topic for many years together. So it shouldn't be a real surprise that there is a lot of agreement between us. The only thing is that if you are in a center and you have a proactive approach to all spina bifida patients, most of the patients are started on CIC and anticholinergic medication without doing urodynamics at first. And the reason for that is that in all spina bifida patients that have been closed postnatally, there is a period of about 3 months of spinal shock. And you don't want to do urodynamics during that period. In children that have had their closure in utero, the first urodynamic studies can be done a little bit earlier, usually in the first weeks after birth. But I don't think you need urodynamics in order to be proactive and to be on the safe side to prevent all the other secondary changes of the bladder wall. So I'm quite happy with that. And if you do the first urodynamics or a second urodynamics and you find changes that are of concern, so you want to modify the treatment, we will give them a period of at least 3 months before we repeat the urodynamic studies to see whether it's effective or not. But otherwise, I completely agree with the answers you have given. So back to you, Giovanni.
Yeah. Dr. Thanks, Rien. And Dr. Zymak, do you have any other comments on this?
I'm sorry. Thank you very much for your amazing presentation and for your comments. And now, і зараз ми можемо дуже плавно перейти до анонсу нашого наступного вебінару. Він саме буде присвячений уродинаміці. The theme of our next webinar is urodynamic. Yes?
Yeah. Thank you, Dr. Zymak, for introducing the next webinar. The next webinar will be held the 8th of February, and we will proud to have with us again Professor Rien Nijman that will present. He will present urodynamics, and I invite you to be present because, as we have seen today, with his great experience, I believe that you can receive a lot of very practical suggestions in how to perform and how to use urodynamics, because we have always to remember that we have to treat the patient and not to treat the urodynamic pattern only. And with his great clinical experience, and I believe that could be very, very useful for all. And you see the other webinar that we have scheduled for the And as I told you, and could be very useful to receive by all of you, some requests for the next series of webinars that we would like to organize after this first series in the fall and the next winter. And for the question, as you know, if you haven't time to send us the question, and please remember that you can send later, and you can write, please Darren, show your address. That could be very useful, and you can send the question later, and of course you will receive the answer in the next webinar, as we have done in this webinar, and the answer we will publish also on the website. And very important for everyone who attends the live webinar today, you could receive the certificate of attendance, and 1 hour after the scheduled finish time of the webinar, you will also receive a survey to complete. Please do that, because your suggestion is very useful. And those who complete the survey, we also receive a certificate confirming the hour of 1 credit and for this webinar. And Dr. Zymak, Professor Rien Nijman, I leave the podium to you. And thanks to all.
Дякую, пане Мосієло. Я хочу нагадати всім нашим учасникам, що кожен учасник зможе отримати сертифікат участі, і якщо він відповість на питання, отримає ще так само 1 міжнародний кредит. Стосовно запитань, хочу вам нагадати, що самі запитання і відповіді на них ви зможете прочитати, зайшовши на сайт ERN. І сюди ж так само і листом ви можете задавати будь-які інші питання, які у вас виникли під час сьогоднішнього вебінару. І ще 2 слова так само хочу додати про наступний вебінар, в якому спікером буде шанований професор Rien Nijman, і він детальніше зупиниться на практичних аспектах уродинамічного обстеження у дітей. Запрошуємо вас долучатись і активно долучатись до наших вебінарів. Доктор Мосієло.
Okay, thanks again, Professor Rien Nijman. Thanks for your participation, and thanks to be available for the next one. Thanks to all participants, and see you in the next webinar on urodynamics. Thanks.
Yeah,
again.
thank you all. See you next week and stay safe.
Thank you. Bye.
Дякуємо усім. Дякуємо, до зустрічі на наступному вебінарі. Bye.
Bye.